بسم الله الرحمن الرحيم. Sudden cardiac death. Sudden is defined as 1 hour or less between the onset of the terminal clinical event and the cardiac arrest itself. Cardiac arrest is abrupt cessation of cardiac pump function that usually requires prompt intervention and usually lead to sudden death in the absence of rapid, effective resuscitation. Note that cardiovascular collapse is a general term denoting loss of effective blood flow due to acute dysfunction of heart or peripheral vasculature. For example, vasovagal syncope, postural hypotension with syncope, neurocardiogenic syncope, which may reverse spontaneously or with intervention. These items differ from sudden cardiac death. Causes of unexpected sudden cardiac death. Cardiac arrhythmias. For example, ventricular fibrillation, VF. Many factors contribute to ventricular fibrillation or ventricular tachycardia. For example, ischemic heart disease, acute myocardial infarction, acute coronary syndromes in general, fulminant myocarditis, hypertrophic cardiomyopathy, electrolyte imbalance, long QT syndrome, cocaine toxicity or overdose, digitalis toxicity, drug interactions, terminal stages of dilated cardiomyopathy, right ventricular dysplasia or right ventricular arrhythmogenic syndromes, also VTAC can cause sudden cardiac death, ventricular tachycardia, if not management rapidly because it dissociates to ventricular fibrillation. Another item is sudden pump failure. For example, an acute myocardial infarction with myocardial rupture or chordae tendineae rupture, aortic dissection, valve avulsion or chordal rupture. Another cause is acute circulatory obstruction, for example, pulmonary embolism, ball and valve thrombus over the mitral valve. Another cause, vasomotor collapse in advanced pulmonary hypertension, associated usually with marked diminution in the cardiac output. Another cause, conducting system disease, as sick sinus syndrome, Wolff-Parkinson-White syndrome. These are conduction abnormalities in the conducting system of the heart that lead to life-threatening arrhythmias and death. Diagnosis and management. Continuous ECG to diagnose the mechanism of the sudden cardiac arrest, sudden cardiac failure. ECG usually reveals ventricular fibrillation VF or ventricular tachycardia VTAC or asystole or electromechanical dissociation, also named pulseless electrical activity. That is to say, there is ECG, P, QRS complex and T, but no corresponding contraction and effective cardiac output. Electromechanical dissociation usually occurs or associated with or complicates hypovolemia, tension pneumothorax, cardiac tamponading, pulmonary embolism, drug intoxications, hypothermia, neglected, untreated electrolyte disturbance. So, first of all, for diagnosis, continuous ECG to know the underlying mechanism. Then check the consciousness of the victim. Shake and shout. Then check pulse of the victim. Feel the carotid and call for help if no pulse. Quickly place the victim on her or his back on rigid surface. For example, floor or flat bed, and begin basic life support if you are not in the hospital. Ensure of the victim airway. Remove debris in the mouth and pharynx as blood and mucus. Loose and ill-fitting teeth should be removed. Then start abdominal and or chest thrusts if obstruction in the deep oral cavity is suspected or obstruction of the upper way tract is suspected, for example for foreign body or like this, try abdominal or chest thrusts first. Then ensure circulation. External chest compression, if there is absent pulse, must be started rapidly. The heel of one hand is placed over the center of the chest or over the lower sternum, and the heel of the second hand is placed over the first hand with the fingers interlocked over the chest of the victim. Place the heel of one hand over the lower part of the sternum, and then place the heel of your second hand over your first hand with the fingers interlocked. Please keep the arms straight. Then sternum is rhythmically depressed by 5 to 6 centimeters at a rate of 100-120 per minute. Please allow for complete recovery between compressions. 2 effective breaths must be given to the patient for every 30 cardiac compression. 30 compressions to 2 breaths. Ensure breathing. Expired air respiration. After 30 compressions, the victim's airway is opened by tilting the head backward, pulling the chin forward, chin lift. The rescuer takes a deep breath, seals the mouth around the mouth of the victim. 2 effective breaths are given over 1 second each. Self-inflating bags can be used instead if available. This is the basic life support outside the hospital. Advanced cardiac life support in hospital. Usually, ICU special team must be called rapidly. ECG monitoring started, for example, in the emergency room or ER room. Blood pressure continuously monitored. Better intra-arterial if available. Ideally, the patient should be immediately connected to automated external defibrillator, AED, or manual defibrillator if AED is not available. ECG monitoring, blood pressure, AED, or manual defibrillator. Intravenous line, better central as soon as possible. Peripheral if a central one is not initially accepted. This indication of intubation. Intubation is performed as early as possible. In non-intubated cases, oral airway tube or supraglottic one should be placed. For ventricular fibrillation or ventricular tachycardia, VT, VTAC, or VF, what's the management? If ECG reveals ventricular tachycardia or ventricular fibrillation, this type of arrhythmia is shockable one. This type of arrhythmia is shockable. What mean of shockable? That you can use DC shock or direct current shock that stops the electrical activity of the arrhythmogenic focus, giving a chance for the sinus rhythm to resume. For ventricular tachycardia or ventricular fibrillation, usually this arrhythmia is shockable. We can use direct current shock, DC shock. That stops the arrhythmogenic focus and giving a chance the sinus rhythm to resume. ABG and continuous CO2 tension monitoring. Then we give one shock. If the instrument or DC shock instrument is monophasic, 360 joules are given to the patient. The 2 blades for the direct current shock are placed over the chest of the patient. Don't forget to use gel between the skin of the patient and the blade. Don't allow gel between the 2 blades to continue with each other. Then if the instrument is monophasic, we give 360 joules. If biphasic device, we give 2 joules. Or we give the device specific according to the recommendations over the device. Then CPR is immediately resumed after you give the shock about 4-5 cycles. Then check the rhythm rapidly. If still VF or VTAC, again repeat the shock. If resume sinus rhythm, this management will be discussed later now. Or if become asystole, we will manage according to asystole as we will discuss now. So we have 3 chances after giving the DC shock. Either sinus rhythm resumed, or the patient change to asystole, or change to remain VF, or VT, remains ventricular fibrillation or ventricular tachycardia. If remain ventricular tachycardia or ventricular fibrillation, we give another shock. This is the second shock we give to the patient. And then continue CPR for about 5 cycles. If no response, we start drugs. Epinephrine, IV or intraosseous, 1 milligram can be repeated. Vasopressin, 40 units IV, once or twice can be given to spare epinephrine doses. And then check again the pulse. If still VF or VTAC, we can give third shock. And then resume CPR rapidly, 5 cycles, and check the rhythm. If still VF or VTAC, we can consider antiarrhythmic drugs or magnesium sulfate and sodium bicarb, and the correction of acidosis, and resume CPR. If no, if remains the same VF or VTAC, we can give shock, CPR, drug, shock, CPR, drug, and to continue for at least 15 minutes. Antiarrhythmic drugs of importance as amiodarone, 300 milligram IV, and then we can give 150 milligram IV later, or lidocaine, 1 to 1.5 milligram per kg bolus and infusion. These are antiarrhythmics most commonly used in VF or VTAC. Magnesium sulfate is important for special entity of ventricular tachycardia named torsade de Bois. Sodium bicarb and the correction of acidosis and electrolyte disturbance is very important to obtain response for our management. This is for VF or VT, ventricular tachycardia and ventricular fibrillation. For asystole or pulseless electrical activity, whether it is from the start pulseless electrical activity or asystole, or after management of VF or VTAC, the patient change to asystole or pulseless electrical activity, the management is the same. start CPR rapidly and give vasopressor epinephrine 1 milligram IV, can be repeated every 3 to 5 minutes. Vasopressin can be given once or even twice to spare the doses of epinephrine IV. Atropine 1 milligram no longer used due to pupillary dilatation and interfere with the diagnosis or proper diagnosis of brain death. Sodium bicarb for acidosis. Continue CPR in patient with asystole or pulsed electrical activity if there is still asystole or pulsed electrical activity in spite of drug until pacing is available, either external or placing one. Cardiac pacing, external or placing internal one. And vigorously treat the cause of asystole or pulseless electrical activity. Usually, again, the cause usually hypoxia, hypovolemia, hyper or hypokalemia, hypothermia, tension pneumothorax, tamponade, toxins, thromboembolism. You treat the systole or the pulse electrical activity, and at the same time you treat or manage the cause. If pulse and normal electrical and mechanical cardiac activity could be resumed, post-resuscitation care is started with ICU. Induced hypothermia to reduce metabolic needs and cerebral edema. Management of predisposing factors or management of the etiology. Some conditions as hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia, Wolff Parkinson White syndrome, that is the cause of arrest or VF or VTAC is primarily conducting system disease. Electrophysiological study is very important, and in this patient implantable cardioverter defibrillator of special importance in some cases. If the patient is ischemic heart disease, coronary case, and total revascularization, some conditions will need antiarrhythmic drugs forever. What's the prognosis of patient with sudden cardiac death? Prognosis to biologic death depend on the mechanism of cardiac arrest, the cause, and the delay before intervention. Ventricular fibrillation or asystole without CPR within 4 to 6 minutes has poor outcome even if defibrillation is successful, because you can resume the sinus rhythm, but brain death occurs and this occurs finally. Thank you. اخدت الفلاشه بتاعتي؟
لا الفلاشة اهي.